This presentation will cover the DSM-5 diagnostic criteria and treatments for generalized anxiety disorder, social anxiety disorder, and separation anxiety disorder. The objectives for our presentation include the APRN will be able to accurately diagnose generalized anxiety disorder, separation anxiety disorder, and social anxiety disorder in children and adolescents using the DSM-5 diagnostic criteria. The APRN will be able to identify appropriate pharmacological and non-pharmacological treatments for GAD, separation anxiety disorder, and social anxiety disorder in children and adolescents. The APRN will be able to safely prescribe and manage medications for the treatment of GAD, separation anxiety disorder, and social anxiety disorder in children and adolescents. Anxiety disorders are the most common psychiatric disorders diagnosed in children and adolescents. These disorders include generalized anxiety disorder, separation anxiety disorder, social anxiety disorder, panic disorder, selective mutism, specific phobia, and agoraphobia. These conditions greatly impact the child's education, family life, peer relationships, and social development. Unfortunately, these disorders often continue into adulthood and frequently co-occur with depression and substance abuse. Left untreated and unmanaged, they often lead to occupational impairment and suicidal thinking and behaviors. Approximately 15 to 20% of youth in the general population struggle with anxiety disorders. Among children with ADHD, the rate appears to be even higher. Generalized anxiety disorder is more often found in females than in males. Although panic attacks are considered the hallmark of anxiety disorders, GAD is different as the individual does not always present with panic attacks. Symptoms of anxiety include increased motor tension, which includes restlessness, fatigability, and muscle tension, autonomic hyperactivity, which includes cold hands, rapid heart rate, shortness of breath, dizziness and dry mouth, and amplified vigilance. This includes impaired concentration and increased startle response. According to the DSM-5, when assessing for GAD, the patient should have the following: presence of excessive anxiety and worry concerning several topics, activities, and events. The worry occurs more often than not for at least 6 months, and it should be clearly excessive. The anxiety or worry causes significant impairment in important areas of functioning. The worry is difficult to control. The symptoms are not caused by another psychiatric or medical disorder. The worry and anxiety should be accompanied by at least one of the following cognitive or physical symptoms in children, and at least 3 of the symptoms should be present to make a diagnosis in adults. These symptoms are tiring easily, irritability, which is either observed by others or is subjective, impaired concentration or feeling as if the mind goes blank, restlessness, sleeping difficulties, and increased muscle soreness or aches. There are some unique symptoms of anxiety in children and adolescents. These include difficulty swallowing, stomach aches, frequent urge for urination, and excessive worry about their competence and performance at school or in sporting events, personal safety, safety of family members, and natural disaster and future events. Social anxiety disorder is more often found in females than in males and usually first occurs in adolescents between the ages of 8 and 15. Symptoms which stem from fear, anxiety, and avoidance often arise after a humiliating or embarrassing experience. In order to meet DSM-5 diagnostic criteria, the child must exhibit the following: significant fear or anxiety about one or more social situations where the person may experience scrutiny by others. To make a diagnosis in children, the child's anxiety must occur in their peer interactions, not just in their interactions with adults. The person is worried that he or she will display symptoms of anxiety which will be negatively assessed by others. Social situations cause fear and anxiety. Social situations are often avoided and endured due to the fear and anxiety. The anxiety and fear are out of proportion to the situation. The anxiety, fear, or avoidance lasts for 6 months or more. The symptoms cause significant impairment in an area of functioning. The symptoms are not caused by a substance or medical condition. The symptoms are not better explained by another psychiatric condition. And if a medical condition is present, the fear, anxiety, and avoidance are clearly not related to the medical condition. Separation anxiety disorder is the most common psychiatric disorder in children under the age of 12 months, and it is equally common in males and females. The prevalence of the disorder decreases from childhood to adulthood. In order to meet the DSM-5 diagnostic criteria, the child must exhibit 3 of the following: repeated and excessive distress when separating or anticipating separation from an attachment figure, persistent and excessive worry about losing an attachment figure, persistent and excessive worry about experiencing an event that causes separation from an attachment figure, refusing to go out of the home or to school or to physically separate from an attachment figure, persistent or excessive fear about being alone or away from the attachment figure, persistent reluctance or refusal to sleep without the attachment figure being close by. Recurrent nightmare about separation from the attachment figure, or persistent somatic symptoms when the child is separated from or is anticipating separation from an attachment figure. The fear, anxiety, or avoidance must be present for at least 4 weeks in children and adolescents. It must cause clinically significant distress in important areas of functioning such as school or other areas, and the symptoms cannot be better explained by another psychiatric disorder. Selective serotonin reuptake inhibitors are recommended as first-line pharmacologic treatment for children and adolescents with GAD, social anxiety, and separation anxiety. There have been few studies on the effects of antidepressants on specific phobia, obsessive-compulsive disorder, and selective mutism in children and adolescents. All of the drugs in this class are used off-label for GAD, social anxiety disorder, and separation anxiety disorder. Escitalopram is FDA approved for major depressive disorder in children ages 12 and older. Fluoxetine is FDA approved for major depressive disorder in ages 8 and older, and for OCD in ages 7 and older. The FDA reports seizures have been associated with fluoxetine and should be used with caution in patients with seizure disorders. The drug can also cause prolonged QT intervals and ventricular arrhythmias, including torsades. Patients taking another QT interval prolonging medication should not take fluoxetine. Fluvoxamine is FDA approved for OCD in children ages 8 and older. Sertraline is FDA approved for OCD in children ages 6 and older. Studies have shown that there were statistically significant improvements with the use of all of the above SSRIs in the treatment of anxiety symptoms in children and adolescents who were diagnosed with GAD, separation anxiety, and social anxiety. The most common side effects in this population are headaches, gastric upset, and insomnia. It is important to monitor for activation behavioral disinhibition, and any negative change in behavior. There is a risk of serotonin syndrome. This includes hyperthermia, hypertension, confusion, hallucinations, weakness, ataxia, and dizziness. Things that should be considered when choosing an SSRI include side effects, duration of action, patient compliance, and positive response in a blood relative. Serotonin norepinephrine reuptake inhibitors are recommended as second-line pharmacologic treatment. Duloxetine is FDA approved to treat GAD in ages 7 and older. Studies using venlafaxine to treat symptoms of anxiety and GAD in children and adolescents have shown that the drug is effective and well tolerated. Increased cholesterol, weight loss, and hypertension have been found in those taking duloxetine and venlafaxine. Therefore, blood pressure, heart rate, weight, and cholesterol levels should be frequently monitored. The use of benzodiazepines in children and adolescents should be avoided if possible. They should be used with caution and close monitoring due to a risk of dependence and side effects. They have not been systematically evaluated in children and adolescents. There is a risk of dependence with as little as 2 weeks of use. If you use these medications, they should be used for a short duration. It is recommended about 1 to 2 weeks of use while other long-term treatments are being put into place. The medication should be tapered off gradually, and side effects, most common in children and adolescents, are dry mouth and sedation. The two tricyclics most often studied for the treatment of anxiety disorder in children and adolescents are clomipramine and imipramine. Clomipramine is not recommended as a first-line agent due to its association with cardiac toxicity. The FDA states seizures were reported during pre-market evaluation of clomipramine. Caution should be exercised when used in patients with a history of seizures. Irritability and outbursts of anger were common adverse effects of imipramine reported in studies when used in children and adolescents. In general, side effects of these medications are mostly anticholinergic. The most frequently seen side effect in children was dry mouth and constipation. Dizziness and sedation were also noted. Tricyclics can lead to rapid or irregular heartbeats. Prior to starting a tricyclic, it is recommended that the child receive a baseline ECG, vital signs, and baseline labs. Tricyclics should not be used in those with elevated cardiac risks. Before prescribing these medications, you should determine if the benefit outweighs the risks for your particular patient. It is important to note that overdose of tricyclics can be lethal. To date, there have been no well-designed controlled trials using buspirone to treat anxiety in children and adolescents. The medication has not been shown to be effective in treating GAD, social anxiety, or separation anxiety in children and adolescents. Studies have shown no statistically significant difference between buspirone and placebo in reducing symptoms of anxiety in children and adolescents. When prescribing psychotropic medications to children and adolescents, it is recommended that you only initiate one medication at a time to avoid effects of drug-drug interactions and to discern which side effects are being caused by which medication. You should consider comorbid disorders. The medications for anxiety disorders can also help reduce the symptoms of other psychiatric disorders. You should consider family history of medication treatment. If a child's blood relative had good results using a particular medication, it could suggest that the same medication may be effective for the child. When prescribing psychotropic medications to children and adolescents, the FDA recommends that you should start with the lowest dose available and slowly titrate to the lowest therapeutic dose. The medication can be increased weekly if the child is tolerating the medication. The FDA recommends close monitoring of children and adolescents, especially in the first few weeks of antidepressant treatment, because this is when the child is at a higher risk for experiencing suicidal thoughts or behaviors associated with antidepressant treatment. It is also when the child is more likely to experience side effects or other adverse effects. The FDA also recommends that the use of medications be limited to the shortest duration possible. Antidepressant medications for children often require dosages similar to adults because of the increased metabolism found in children and adolescents. That is, the therapeutic dose for children and adolescents is often the same as adults. The clinician must weigh the risk with the potential benefits before prescribing psychotropic medications to children and adolescents. When discontinuing an SSRI, it is recommended that the clinician decrease the dose gradually by 25 to 50% a week in order to avoid discontinuation syndrome. During the tapering period, the clinicians should carefully monitor the child and adolescent for unwanted symptoms or sudden changes in mood or behavior. Antidepressant medications for children often require dosages similar to adults because of the increased metabolism found in children and adolescents. That is, the therapeutic dose for children and adolescents is often the same as adults. The clinician must weigh the risk with potential benefits before prescribing psychotropic medications to children and adolescents. When discontinuing an SSRI, it is recommended that the clinician decrease the dose gradually by 25 to 50% a week in order to avoid discontinuation syndrome. During the tapering period, the clinician should carefully monitor the child and adolescent for unwanted symptoms or sudden changes in mood or behavior. The FDA recommends a medication-free trial for patients who experience improvement in their anxiety symptoms for 1 year. This should be done when the child is in a period of low stress, and the medication should be resumed if the symptoms return. Long-term effects of antidepressants are not known. The FDA has included a black box warning on all antidepressants to warn of a possible increase in suicidal thinking and behaviors in children, adolescents, and young adults under the age of 24. It is estimated that 1 to 2% of children taking antidepressants experience suicidal thinking as a result. Close monitoring, particularly in the first 2 weeks of treatment, is important as the highest risk of emergence of suicidal thinking has been found to be in the first 2 weeks of treatment with an antidepressant. The reason for the association between antidepressant medication and suicidal thinking and behaviors is unknown. Cognitive behavioral therapy, or CBT, is considered first-line therapy for the treatment of anxiety disorders in children and adolescents. CBT with pharmacologic therapy has been found to be more effective than CBT or pharmacologic therapy alone. CBT alone, medication, and CBT with medication were all found to be more effective than placebo. Studies have shown that the treatment effects of the therapies were sustained at a 6-year follow-up. CBT can be provided individually, in groups, or with parents. CBT with the child and the parent has been found to be especially effective in treating symptoms of anxiety in children and adolescents. In this therapy, psychoeducation is provided, caregiver coping skills are taught, Parent training is provided, and parents are taught how to utilize techniques to help their child cope with anxiety. Mindfulness therapies focus on the present moment, the here and now. Studies in mindfulness-based therapies in children and adolescents with anxiety disorders have been limited. However, group-based mindfulness-based cognitive behavioral therapy demonstrated effectiveness in treating children and adolescents with GAD, social anxiety, and separation anxiety in a few studies. Treatment with CBT in children under the age of 7 is up for debate. It is debated whether or not children under the age of 7 are able to fully participate in CBT. Some believe that they do not have the cognitive capabilities to benefit from this form of treatment. As mentioned previously, CBT that includes the parent has been found to be the most effective. Since parents' behaviors have a significant impact on the child and the child's anxiety, studies have demonstrated that CBT-based programs that include the parent with the child or with the parent alone has been shown to be effective in reducing anxiety in 2 to 9-year-olds. There have been drug studies using SSRIs and SNRIs for the treatment of anxiety disorders in children as young as 5 years old. However, the results of these studies have been widely variable. Professional societies and organizations have slightly different treatment recommendations. The American Academy of Child and Adolescent Psychiatry recommends CBT for mild to moderate anxiety. CBT with an SSRI is recommended for more severe symptoms of anxiety or when CBT alone has not been effective. CBT with an SSRI, along with the addition of an SNRI, a benzodiazepine or buspirone, can be used as an adjunct to SSRIs if needed. The National Institute for Healthcare Excellence 2013 guideline recommends that no pharmacologic treatment be used for social anxiety in children younger than 18. Instead, they recommend CBT or other therapies be used. The British Columbia Medical Services Commission recommends SSRIs should be used to treat anxiety disorders in children and adolescents only if CBT has failed. When evaluating treatment outcomes, subjective reports from the child or adolescent, parents or caregivers, teachers, and clinician can be used. Formal rating scales such as the Hamilton Anxiety Rating Scale, the GAD-7, Severity Measure for Generalized Anxiety Disorder, and Vanderbilt Assessment Scales can also be used. If formal measurements are used, it is recommended that the rating scale be used prior to initiating treatment so that pre- and post-treatment scores can be compared.